4 different doctors, 7 long years. Imagine a woman in her mid-30s completely lost in a medical maze while her body changes right before her eyes. Her cycles are disappearing for months at a time. She's fighting deep, painful cystic acne that resists every cream and wash on the market. She's noticing coarse, dark hair in places she never had it before, and she's putting on weight despite not changing a single habit. Her PCP tells her she's just stressed. Her dermatologist gives her antibiotics. Her gynecologist hands her a prescription for the birth control pill to force an artificial menstrual period. And her endocrinologist runs a basic thyroid panel, like a TSH, and tells her it's normal, sends her right back to the starting line. This wasn't just bad luck. This is exactly what the label Polycystic Ovary Syndrome did to millions of women for over 40 years. By anchoring the name to cysts on the ovaries, and they're not true pathologic cysts at all, they're simply tiny immature follicles frozen in development, the medical system turned a systemic whole body metabolic condition into a localized reproductive issue. Care became completely fragmented. Specialists treated isolated pieces of the puzzle instead of looking at the whole picture, and women were repeatedly told their symptoms were just normal parts of being a woman. The name itself held back better care for generations until now. On May 12, 2026, the PCOS name was discarded for a much more accurate medical term, PMOS, or Polyendocrine Metabolic Ovarian Syndrome. Now, for those who lived with that PCOS label, there was never a cure, just a revolving door of symptom management from a handful of different specialists. And that's because the old name anchored clinical thinking to a visual finding on an ultrasound that never told the whole story. If we look back, this whole misunderstanding started in 1935 with Stein and Leventhal. They described women who had missing cycles linked to enlarged ovaries with multiple small fluid sacs. That early work was a foundational starting point, absolutely. But as our diagnostic criteria evolved over the decades, from the NIH guidelines in 1990 to the Rotterdam criteria in 2003, and on through the updates in 2023, the name stayed stubbornly tied to polycystic ovaries. Think about how misleading that really is. Up to 30% of women who have this metabolic syndrome don't even show that string of pearls follicle pattern on an ultrasound. Yet, because they lacked the visual cysts, their metabolic warning signs were completely missed. This narrow framing is what led to decades of fragmented care. Gynecologists focused almost exclusively on regulating cycles with synthetic hormones. Dermatologists targeted the skin and hair. Endocrinologists looked at isolated thyroid or adrenal markers. But almost nobody was putting the central driver, cellular insulin resistance, which is present in up to 88% of these cases, right in the center of the treatment plan. Instead, symptoms were minimized, diagnoses were delayed by years, and serious cardiovascular and metabolic risks were left to quietly build up in the background. The old name didn't just delay answers, it shaped an entire era of incomplete Band-Aid care that left women carrying a heavy, unnecessary burden for decades.